Let's talk about rheumatic fever. Why is it called rheumatic fever? Because the joints get involved. There's an arthritis, specifically the large joints, usually, and it's going to migrate. It's going to be a migratory, transient, self resolving polyarthritis. And the patient's going to have a fever at the same time, and the patient's typically a child or an adolescent. And that's acute rheumatic fever. And it's antecedent roughly 2 weeks to a month to a couple of months after a Streptococcus pyogenes pharyngitis episode. And so that's strep throat. And the reason why you get rheumatic fever and possibly rheumatic heart disease secondary to strep throat is because of this thing called molecular mimicry involving the M protein of Streptococcus pyogenes, which looks very similar to a protein expressed on cardiac myosin. And so when the immune system attacks M protein, well, the antibodies that it generates may stick around depending on the shape of your cardiac myosin and the shapes of your antibodies. And the antibodies can attack your own heart after a certain period of time. So that's the presentation of rheumatic heart disease. And specifically, it can, well, non-specifically rather, it can cause a pancarditis, meaning it can kind of attack any layer of your heart, or at least the inflammation generated by the immune attack can affect any layer of your heart. So you can get an endomyopericarditis. And the most typical sequelae to the inflammation is going to be valvular damage, regurgitations, and then congestive heart failure secondary to such a regurgitation. So looking at this outline, I believe that there's going to be one question for sure on myocarditis. There may be a question on pericarditis. There is definitely going to be two, maybe three or even four questions involving valvular complications of rheumatic heart disease. I believe that the virulence factors of strep pyogenes, the capsule that it has, are fair game. I think that it's important to know that we test for it with anti-streptolysin O because you're almost never going to see culture positive blood. And I think it's important to know that it's a beta hemolytic strep, so it's going to be red on an agar plate. Let's get into it. Strep pyogenes. Anytime you get rheumatic fever, you had to have had strep throat. You can't get rheumatic fever following just a strep skin infection. It's very common in the Eastern world. I mean, especially relatively, extremely common, 10 per 100,000, or I'm sorry, 10 per 1,000 compared to 5 per 100,000 here in America. So the proportions are drastic and dramatic. And so that's something you can derive out of a question stem involving an immigrant, or maybe you're the doctor in a different country in the question stem. That's how it can be presented. Acute rheumatic fever, meaning the follow-up to the strep infection itself, is going to be most common in kids 5 to 15 age group, but then rheumatic heart disease, which is going to involve the pancarditis and the valvular complications, that's going to present typically in early adulthood. So it's an autoimmune reaction, again, a molecular mimicry involving the M protein. Remember, sketchy, that's the Pi Genie Baker wearing the bicuspid mitral type hat, right? And it's got an M on it for M protein. And we think that there's some sort of HLA component, some sort of hereditary component to the autoimmune reaction against M protein. That's all that this page is saying. And anytime you have an autoimmune reaction, you've got all sorts of immune cells within a histology slice of whatever affected tissue you're looking at. And finally, Sydenham-Correa. That is a neurologic manifestation of rheumatic fever, and that's part of the Jones criteria. That's the S. And at the bottom of this page, curiously, Sydenham's-Correa might have an autoimmune component as well, in which your immune system produces antibodies targeting the basal ganglia specifically. And what else do we know in the basal ganglia that causes a Correa? Huntington's disease, which has got those expanding CAG repeats. And the possible question right there, what disease presents similarly, you know? So moving into the clinical presentation of rheumatic fever. Again, there's going to be a latent period. you get strep throat, and then there's some time that passes, and then you start seeing the presentation of rheumatic fever through the Jones criteria. And the major clinical manifestations here are the major manifestations of the Jones criteria. And to diagnose rheumatic fever, you need two major or one major and two minor criteria. And so this page and a bit of the next lists the major criteria. Polyarthritis is one. Polyarthritis is the most common. The acronym Jones, remember that in the sketchy video, we've got the 5 cupcakes with the J, the heart, the N, the E, and the S. And the Jones criteria, conveniently, there's a mnemonic for it. It's joints. The O is carditis. The O is a heart. And then the N is nodules. The E is the erythema. And the S is Sydenham's chorea. So J is joints. You've got a migratory arthritis. That means that it can go from one joint to another. It'll affect the large joints. The kid's going to be in a lot of pain, but it'll be self-limiting. And when you joint biopsy, you're going to see neutrophils, but you're not going to be able to grow anything. And so the neutrophils are going to clue you into some sort of immune reaction going on. And then when you combine that with the upper respiratory infection 2 or 3 weeks prior, you're going to get a picture of strep in your mind. So the carditis, it is going to be a pancarditis, and this is the second most common involvement or presentation of rheumatic fever. And it can be self-limiting, and it can be episodic too, because it's an autoimmune reaction. So it's like you're going to make a lot of antibodies, and then you're going to cool off and get your M2 macrophages to chill everyone out and rebuild the damage and scar everything up. But then maybe one of your immune cells is going to see that cardiac myosin again, and it's going to present it to some B cells or some macrophages, and then the whole thing will start over again, and you'll get inflammation, and then it'll cool off, and then you'll get more inflammation, and then it'll cool off again. And so that's how autoimmune disorders tend to play out for a patient symptomatically, is episodically. It's very, very rarely, oh, you're on high alert at all times. So the carditis is going to go like that. It'll hit in waves, and every time it hits, it'll degrade some tissue, and the most vulnerable tissue in your heart to this sort of rheumatic fever inflammation is going to be your valves, because they're thin and they're largely endothelium, and they've got a lot of fibroblasts that can throw down collagen anytime they see inflammation. So that's why your valves are preferentially involved here in rheumatic fever. And then this can lead to either a regurgitation or a stenosis, or even both in some cases. And so we also have an SDL about valvular manifestations, valvular pathologies. You could certainly just get a pure valvular question, but then the twist in it is going to involve something from this SDL, and it would count as a question from here. Sydenham's chorea. Chorea is going to be like spastic, erratic. That's a good word. Kind of spasmodic movements with no rhyme or reason to them. And patient might have dysarthria alongside that. And then emotional lability is characteristic. We see this in Huntington's too, because of the erosion of the caudate nucleus. That does have some role in emotional processing, communicating between your lower brain and your cortex. Typically self-limiting. There's a characteristic rash for rheumatic fever. It's called erythema marginatum. And erythema marginatum is kind of thin and lacy, and it's got a serpiginous border. That's a word commonly used to describe it. And it'll spread, and it's mobile. It'll move along a patient's trunk over a course of days. It'll spread, from right to left or whatever direction. And it'll eventually go away on its own. It can stick around. It can disappear in minutes to hours. So that's the erythema. That's the rash. Then finally, nodules. These are going to be immune complex deposits, essentially, because you've got this immune complex generating reaction against M protein. And there's going to be complexes that get stuck in your small blood vessels, and your immune system is going to react so as to clear out those complexes from your microvasculature. And that's whenever those immune cells aggregate, that's the nodule. Then also you're going to see fever most of the time. You're going to see elevated acute phase proteins, and you're going to see a peripheral leukocytosis. So blood cultures are usually negative because, again, rheumatic fever is most always going to be at least 2 weeks following the initial strep infection, but even can be up to a month or two. And so there's going to be no bacteremia, there's going to be the blood culture is negative. And so how do you test to see if they had a strep infection versus something else, if they do report an infection? And the answer to that is the anti-streptolysin titer, because these antibodies that we produce against an active strep infection happen to stick around in your bloodstream for a pretty long time afterwards. And anti-streptolysin is the best test out of the three listed here. Go with the ASO if they ask what's the preferential method of diagnosis. Now we get into the Jones criteria. Again, you need 2 major or 1 major, 2 minor from the Jones criteria. And it's a little different between low risk and high risk population, but it's similar enough to where you can kind of, throw it in your head together and kind of treat everyone with just like, joints, carditis, nodules, erythema, synonyms. So Jones, that's the mnemonic. That applies to both low and high risk. And then the cutoffs for minor criteria, those are a little bit different between low and high risk, but the text doesn't really talk about like what's a low risk, what's a high risk, because so I'm just going to assume, high risk children from countries that have a high incidence of strep, and low risk is going to be adults and children from the Western world where there's not as high a prevalence of strep pyogenes infection. But I don't think you'll get a test question on risk. Supporting evidence is established by an ASO titer. Other antibodies work if you can't find ASO in the blood. So now let's move into the pathology of acute rheumatic heart disease, and then we're going to talk about chronic rheumatic heart disease. So when the autoantibodies first kick in, when the molecular mimicry first kicks in, you very commonly get a pancarditis or some sort of carditis, which is inflammation of the heart. It can be an endocarditis, it can be a myocarditis, it can involve the pericardium, which we know is continuous with the epicardium. And so the pericarditis, that's your epicarditis. Endocarditis is going to involve the mitral valve most frequently, and then the aortic valve second most frequently. So you're usually going to see it on the left side of the heart, which makes a lot of sense because the left side of the heart generates a lot of pressure. So you'll see vegetative growths along different valves in rheumatic heart disease. And the growths are going to look very similarly to other types of endocarditis. It's going to be tough to differentiate them just based on a picture alone. So they're going to have to give you something in the question stem involving the patient history and prior exposure to an infection in order to establish that it is indeed a rheumatic endocarditis. So the endocarditis is what's pictured here in the middle, and the myocarditis, in contrast, is here on the right. And what we're seeing here in the myocarditis is a granulomatous lesion. So it's like a granuloma, but it's not a granuloma. So we're seeing a granulomatous lesion in between bundles of skeletal muscle, cardiac muscle. So all down here, that part there, that's a big old cut of heart muscle. And there's a packet of heart muscle. And then up at the top, there's some heart muscle too. And so this big Granulomatous lesion is sitting interstitially in between these bundles of cardiac muscles. So that's what it's going to look like. So you can imagine there's a lot of inflammation there, and the inflammation can propagate inwards to the endocardium, outwards to the pericardium. So when we're looking at the myocarditis specifically, there's histological grades involved with the stages of infection or the timing of the myocarditis. And specifically, there's early phase, then it peaks, and then there's late phase. And when it's early, you're going to see real non-specific findings, including fibrinoid necrosis, which we know is going to be damage to vasculature, damage to the endothelium of some vasculature. But then when you get into the granulomatous phase, that's when the granuloma-like lesions in between muscle bundles will begin to develop. So if you see something like this on the left on page 8 here, you know that you're looking at an intermediate phase lesion. You know that you're looking at rheumatic fever because it's got these things called Aschoff giant cells. And you also know you're looking at rheumatic fever specifically because it's a big clump of reactive immune cells in between bundles of skeletal muscle, cardiac muscle. And so you see the cardiac muscle at the top edge of this picture, and that's like a fascicle, you know. It's got a paramycium around it. And in between these two bundles, in this zone here, that's where you've got this interstitial granulomatous lesion that is super characteristic of rheumatic fever. So bottom of page 7, that's just telling you with words what you will see on histology. And we know that that's a very common route of questioning, to ask you what you will see on histology when given a clinical picture. So there it is in words, here it is in pictures. So Aschoff giant cells are basophilic, and anything that's basophilic has a lot of nuclear components to it, DNA or RNA. And it makes sense that these giant cells have a lot of RNA inside them because they're basically a syncytium or a fusion of cells. And the Aschoff giant cell is composed of these smaller abnormal cells called Anich cells. And those are going to be like owl eye or caterpillar type cells. And you see a whole ton of them here in this picture on the right. I mean, like, here's one, here's one. They're all over the place. And they kind of look like tadpoles up in here. But again, they stain very darkly in the middle, very, very darkly. Taking another look here on the left, you can tell you got an Aschoff giant cell. And what's this? You can tell that at the margins of this frame, in the upper left and lower right corners, you see cardiac muscle. So you know that this giant cell is situated in between bands of cardiac muscle, and that's going to be what lets you say, rheumatic. Then here we go with more Anich cells. These aren't the giant cells. These are the cells that make the giant cells. I don't think it's a giant, I don't think it's a big difference. You know, I don't think it's test worthy, but that's what they look like. So that's your peak phase myocarditis. And as it progresses, it burns itself out. We're saying that any autoimmune reaction is going to be episodic. It's going to have a lot of inflammation, then it cools off, and then a lot of inflammation, then it cools off, and then a lot, and then it cools off. And so that's how the cellular picture of this myocarditis will progress, is that, you get a lot of giant cells, you got a lot of inflammation, then it scars up. And then you see a lot of giant cells again, and you'll see a lot of inflammation again, and the giant cells are the inflammatory cells reacting to the M protein, or rather to your own myosin, and then it cools off again. And then finally, the pericardium can be involved. I haven't seen it in a practice question, but that makes me think that we're prone to get a question on it at some point, because there's a few different ways that you can get pericarditis, and it's always going to present as this friction rub, and the patient's going to feel better when they sit up, and they're going to feel worse when they lay down. And that's a pericarditis. And it can be a restrictive pericarditis. We just had an exam question about that. Or it can be non-restrictive, and it can be transient. It can go away on its own. And it can be autoimmune in the case of Dressler's, and that's a post-AMI pericarditis. And so pericarditis is typically going to resolve on its own without any complications to it. But as we know, if it's restrictive, it can engender heart failure. So I want to take a little bit of time now and look at some gross lesions, couple of aortic valves. We know rheumatic valve disease typically is going to affect the mitral valve, but this is a good picture of an aortic valve. And you know that it's an aortic valve because it's got three sinuses to it, right? So it's got this little sinus, and these are called the sinuses of Valsalva. It's got 1, 2, and 3 sinuses. So even though the lumen of this valve is kind of flat, as you would expect a mitral valve lumen to be, this is an aortic valve, right? And this being an aortic valve, the test question was essentially, well, why is it stenotic? And the answer is going to be rheumatic valvulitis. And so we know that it's rheumatic valvulitis because you've got clearly 3 valve flaps, so it's not a congenital bicuspid valve. And that's why this was a tricky question, you know, because you see the shape of the lumen, you want to say, oh, they've got a bicuspid aortic valve, but you also don't see any calcifications on it, right? And I don't think that, like, I don't see anything in this picture that makes me think, oh, calcifications, right? Nothing looks too rocky or granular. It's more kind of like a wet, moist fibrinoid type of lesion. And so that makes me say, all right, it's not a bicuspid valve. It's not degeneration. Acute endocarditis, no, because that's going to affect the bottom of the aortic valve, the ventricular side. That's the low pressure side, most commonly. Hypertrophic cardiomyopathy, no, they're not showing you the ventricles, they're showing you the valve. And it's a rheumatic valvulitis because rheumatic fever is specifically involved in the fusion of valve leaflets. And that's what you're seeing in this little triangle here, is that the lumen used to be, you know, totally triangular, but as episodes of autoimmunity accrued against your heart, the inflammation built up and kind of fused the leaflets of this aortic valve together. And so that's a big concept, because it's going to differentiate your rheumatic aortic stenosis and mitral stenosis from something that's age-related, something like a congenital bicuspid valve or something like myxomatous degeneration. So here's another example. Again, you see that the valve leaflets are starting to fuse together, and it's a smooth lesion. It's not a bumpy, rocky, granular lesion like you would see in calcific degeneration. And if you took a slice of the valve, you're going to see a lot of fibrinoid type necrosis. It's going to be pink and wavy, right? But what you're not going to see is big clumps of clot on that valve. And what you're not going to see is big pink eosinophilic chunks of calcium crystal on that valve. Why? Because it's rheumatic in nature. It's autoimmune. There's nothing being deposited. It's an inflammation from within the valve. So now I want to look at a couple of more histology slides just to hammer home this myocarditis and help you differentiate it from other instances of myocarditis. Rheumatic myocarditis is going to have these interstitial granulomatous lesions. And here is one right here on the left half of this picture. You can tell it's a lot of inflammatory cells in between fascicles of cardiac muscle. And then over here looks to be another one that's sort of in the process of forming. But if you zoom in really close, you can tell that these are These are cells with alveoli-type nuclei and large basophilic condensed nuclei, and that's exactly what the text tells us we can expect. Here's another example. What do we see in the middle here? Immune cells. Where is it? In between a big bundle of a lot of skeletal muscle, cut in an axial section. And so that's an interstitial. It's in the interstitium. It's in the extracellular matrix. It's in between myocytes. And a last look at it here. Here are the NHCal cells. Remember, they're the ones that kind of look like a caterpillar. These are all NHCal cells. They're not giant cells. They're individual cells still at this point. And you can tell that they've got a whole lot of patchy necrosis in between them, and it's eosinophilic. That's part of what helps you see it's necrosis. And there's a lot of space in between cells, especially up in the upper right-hand corner here. So you can tell there's some inflammation and some necrosis going on there. And then also look at where is this lesion. Well, you've got this granulomatous type lesion with immune cells, a couple of giant cells in it here. And then you've got on the lower right corner of box A, a lot of muscle cells, a lot of myocytes. And so you know it's interstitial relative to these myocytes. Last one, what are we looking at here? Dense cellularity, macrophages, immune cells, dense basophilic nuclei. And what's around these cells? A bunch of skeletal muscle. So that's your rheumatic myocarditis as opposed to other etiologies of myocarditis on a histology slide. Let's get back to the SDL. So anything that involves valves obviously involves the potential of development of a new murmur, and you ought to know how to recognize different murmurs, and you ought to be able to predict the ramifications of that murmur if expanded in time. And you ought to know that the mitral valve is the most commonly affected valve, followed by the aorta. And the right side of the heart is only going to be affected in about 1 out of 10 patients, and it's always associated with left side involvement too. Here's your pericarditis. Not too much to say here other than that pericarditis is going to present the same all the way around. You know, there's only one way to have a pericarditis really symptomatically. And so your diagnosis is going to be made by a very good history, right? Not by any signs or symptoms, but by asking the patient certain things. And that's going to be reflected in the stem of the question. And if they do have rheumatic heart disease, there's going to be something in that question, whether it's an ASO or patient reporting history of infection, that clues you into the fact that this is rheumatic pericarditis. But then otherwise, if there's nothing in the question stem that lets you say, oh, hey, this person had a strep infection, then something more general is likely to be the answers, like fibrinous pericarditis. So of everyone who gets carditis, about half recover, and then the other half go on to develop chronic rheumatic heart disease. And chronic rheumatic heart disease is characterized by valvular deformities. Could be a stenosis, could be a regurgitation, could be a little bit of both. Most commonly involving the mitral valve, sometimes involving the aortic valve. And we know that we're going to see growths on the heart, sort of pseudo-vegetations, and they're going to look like these smooth fusions of valve leaflets, as we've been looking at. So if you're on the mitral valve and you got a stenosis, well then the two cusps of the mitral valve are just going to get thicker and thicker, and the lumen of the valve is going to get smaller and smaller. And that's reflective of episodic inflammation accompanying an autoimmunity. And then as we see right here, this is very interesting. Even the chorda tendineae can become inflamed, and even the autoimmunity can even span down to the chorda tendineae. So if they get involved, obviously that valve, whichever one they're attached to, is going to have a very tough time opening up, contributing to the stenosis. Here's a good paragraph right here describing how valvular inflammation accrues during the healing phase of each recurrent autoimmune episode. And when the valves get damaged, time and time again, more and more collagen there. So the valves are going to kind of lose mass over time, and they're going to shrink or shrivel up into themselves, and they're certainly going to lose their flexibility. And the sentence talking about commissural fusion that can occur either in the mitral valve as seen at the corners here, or that can occur in the aortic valve as we've seen. Then finally, you're going to see some neovascularization. And if it's episodic, when is the neovascularization going to happen? Well, it's not going to be during the inflammatory phase. It's going to be kind of during the cool down phase, right? And anytime you throw down a bunch of collagen in between cells, then those cells get relatively hypoxic because oxygen doesn't want to have to diffuse through collagen. And then as certain types of cells get hypoxic, they can express VEGF, and the VEGF is going to stimulate neovascularization to start to deliver some oxygen to this scarred up fibrotic tissue. Thinking about the clinical picture, back to it, mitral valve stenosis. Well, it's going to be a left atrial volume overload, which is going to go to a lung volume overload, which is going to go to pulmonary edema, which could be acute depending on what else is going on throughout the rest of your body. And that can be a very, very bad thing. Or if it's more chronic, you're going to see pulmonary hypertension, dyspnea, orthopnea, eventually a right ventricular hypertrophy and a volume back up into the portal veins. And so that's going to present with an ascites, maybe a hepatomegaly, maybe a pitting edema peripherally. So that can, all of that can be downstream from a mitral stenosis. And the left ventricle is going to be volume underloaded, right? And so you're going to see a drop in cardiac output to a tiny, tiny little bit at first, and it's going to get worse and fall off, fall off. Here's a McCallum plaque. This subject was broached in the infective endocarditis SDL as well. And what we need to know here is that anytime you have a flow abnormality within a heart, specifically anytime you have a hole anywhere in the heart, be it a septum or a valve, it's going to create a jet stream of flow, kind of like a water hose, you know. And that hose of flow is going to get sprayed onto a very specific area of the wall of the heart. And the wall of the heart, obviously, over 20 or 30 years, it's not going to like getting blasted in the face with a fire hose. So what is it going to do? It's going to lay down collagen. It's going to lay down extracellular matrix, and it's going to thicken, you know, it's going to grow thick skin reactively because it's getting smacked with a high force of flow. So that's a McCallum patch, and the SDL on infective endocarditis does have a very handy table helping you to coordinate where different McCallum patches can present in the heart given different holes. So mitral versus an aortic regurgitation versus a ventricular septal defect versus an atrial septal defect. Remember, flow is always going to go from high pressure to low. So that's why whenever you have a mitral regurgitation, well, where's the high pressure? In the ventricle. Where's the low pressure? In the atrium. So blood's going to go up into the atrium from the ventricle, and then at the top of the atrium, wherever that flow bounces off the top of the wall, that's where you're going to get the McCallum patch. Clinical presentation can involve mitral stenosis, regurgitation, aortic stenosis, and regurgitation. And again, we have a whole SDL on those as well. And so questions in that sort of style, as you would expect from that SDL, are also fair game here. Just remember. Typically, it's going to be kids getting rheumatic fever. We've got Jones criteria. Joints and carditis are the two most common major presentations out of those five. Jones criteria. Rheumatic heart disease is going to present in the second to fourth decade of life. It's going to be episodic in nature. It's an autoimmune reaction involving the M protein. It's a molecular mimicry type thing. And we're going to treat it with anti-inflammatories. because there's really not much we can do at that point else. Thank you very much for watching.